Yeah, I'm happy to start at another meeting. And we are somehow trying to continue our meetings every last Saturday of the month. And this month, with a lot of other meetings going on, we had half a mind, and there were suggestions that we might miss this meeting and take up next month. But I thought, that should be a very exceptional decision to do that, and we should go ahead. And here we are. And as I told you, there has been a lot of new entrants in the last 2-3 weeks, maybe freshers and juniors. That is good news. And this week we have some illustrious chairpersons, Professor Kashi and Dr. Sampath Kumar. And we have 3 speakers with very interesting themes to discuss. And the theme is plumbing works in nephrology, I thought, because this is mainly to deal with trying to lyse the thrombus in the AV fistula or other vessels, and trying to control bleeding from the tunnel, the post tunnel catheter bleeding in the tunnel, and bleeding kidney, and a novel way to stop it percutaneously. So all these things I thought would come under plumbing works in nephrology, and we have grouped this talks today, and we have great speakers with a lot of experience. And I invite Professor Kashi. Kashi is too well known to us, and he is one of the senior most nephrologists of the country, and he distinctly differs from many other professors that getting into interventional nephrology and getting interested and sharing experiences shoulder to shoulder with younger generation is, I think, very, very unusual feature. And I have great appreciation for him, and we all love you, sir, for your enthusiasm at this stage of your career. Plus, we have learned so much, the practical points and your cutting edge comments, when we get over enthusiastic and do things or pass comments. And another great feature about Professor Kashi is that he's a voracious writer, and not only a writer, he makes others write, and the publications he has made, and he has made others to join him, and I think that's a great thing, great appreciable thing. And we all owe to you, sir, for your continuous efforts to bring more and more teaching material using our patients and our faculty here. And Sampath is again has been one of the pioneer members starting this forum, and he's professor of nephrology in Meenakshi Mission Hospital, and he has held many great posts as administrative role in Southern Chapter, ISN, in Indian Society of Nephrology, in PD Society, and now he is the president of AP Asia Pacific International Nephrology Forum, and that's I think a great proud moment for all of us. Welcome, Dr. Sampath. And the speakers, we have Adrian Secura, who is great international nephrologist with passion for sharing his views, and I like him most because of his enthusiasm to encourage this group, and he has been a regular visitor. He is professor of clinical medicine, Oshner LSU Health, Shreveport, Louisiana, and he has a talk on trying to control bleeding from the tunnel. And Girish Reddy is, I need not say anything about him because he is always there, and I think he is one of the fast developing international nephrologists of the country, and it is a boon for him and for the institute that he has joined Institute of Nephrourology, where his patient reach is so great, and he has been given a free hand to try all his tricks and share them with us. And we have a new guest today, Dr. Senguttuvan Pandian, who is a colleague of Dr. Venkatesh, and he is a consultant vascular interventional radiologist at Apollo Specialty Hospital in Chennai, and Dr. Venkatesh would share something to us to introduce him. Venkatesh?
Yes, sir. So I hope I'm audible, sir. I'm audible, sir.
Yes, Venkatesh.
Yeah. So good evening, all of you. So what shall I say? It's my great pleasure to introduce my senior from my UG days, my close friend, my well-wisher, my colleague, and whatnot, Dr. Sengutuvan. We have been working in close quarters ever since I got into doing this intervention nephrology stuff. It's always been a very innovative guy. So myself, a nephrologist, and he's a radiologist. So I think our ways of thinking and skills are a little different. So always felt working together increase the success rates of whatever we did. That's what is my observation over the last few years. He has been always innovative in whatever we did. Before we wanted to, just to tell you an example, just before we wanted to abandon any procedure, I always ask for a second opinion. If he is convinced like we should not go further, maybe we stop. Otherwise, always has a trick or two up his sleeves. I welcome Dr. Sengutuvan for this meeting. I'm sure he'll be joining us regularly. Thank you.
Welcome, Dr. Sengutuvan. Actually, we have great interventional radiologists and vascular surgeons amongst us, but there are only a few who would not grudge us doing all these procedures and who are ready to help us in times of trouble. So we owe you a lot.
Thank you. Thank
you. Yeah. Dr. Girish, I think you can start. You can share your slide and start your presentation after Professor Kashi and Sampath shares their views here. Kashi sir.
Thank you, Bala, and thank you all the members of the Inform group. I think I must congratulate Bala and his core team for organizing this Inform group, which is growing day by day. It is a very popular group among all the people, seniors as well as juniors, and the meetings are very regular, informative, and I have been following up these meetings as far as possible. We all started. Now, let me just say that I have been lucky and unlucky. Unlucky in the sense that I have never had, after medical college days, I have never had suitable assistants to assist me. So I have to do everything myself. And at this age, I must say, at the age of 76, I still have to do my own subclavian, my own jugular, and my own perm cath insertions. It is lucky that way because I don't think any of my friends and any of my colleagues who are at least about even 20 years junior to me are doing the procedure regularly because they ask their assistants to do. I'll just take a short time to take a story from 1976 to 79, when I used to be the assistant professor of medicine in a medical college in Kottayam, and we have to do ward duty. The night duty in the ward, there are so many deaths, and the protocol there was to give oxygen, give intracardiac adrenaline once the heart has stopped, and then give external cardiac massage, and also give a drug called coramin. That is a standard protocol. Now, I heard one of my senior professors say that doing subclavian is very easy. And in a meeting, he said, if you give me a patient, and if you give me a table, ordinary table and a long needle, I can cannulate a subclavian for you. So that gave me a stimulus. Then I thought, why should instead of giving intracardiac adrenaline, why not I give a subclavian adrenaline, push it into the heart, and whether it is active. Anyway, none of these situations will work. Intracardiac adrenaline is just a protocol, and I'm talking about the days 1976, 78, and that time. So thereafter, whenever there is a death in the ward when I'm on duty, I used to take an LP needle and then do a subclavian, and that gave me a confidence of hitting the subclavian. Then during my training, of course, we learned femoral and other things. Those days we were doing some subclavians only. I ventured into jugulars only in the late 90s. Even at that time, there were no ultrasound guidance or anything. It was only a blind procedure. We had some problems, but we used to do like that. Then thereafter, in the medical college, when we had assistants, DM residents and all, they used to do the procedures, and I had only to watch them or just supervise them. Subsequently, after retirement, I had to start the whole thing over again, and I'm continuing like that. Now, our days, the most important thing for us was the declotting the shunt, the AV shunt. Semino, AV shunt, yeah, AV shunt. There was fistula was less common, and acute renal failure, we had to have a AV shunt, and then the shunt has to be inspected every day. And if the shunt is clotted, we have to do the declotting. There are certain steps for declotting. All that is all gone now. Now we are more involved in the declotting of the perm cath as well as the central veins. Anyway, this has been a great experience, and I am sure that we'll be learning more and more about the newer advances about declotting as well as maintaining and then preventing bleeding from that has been the recent issues, that preventing bleeding from the after removal of these jugular perm cath. I think that is not a major issue. We have not experienced really very many problems, because if we apply 4-finger pressure over the root of the neck at the site of the entry of the catheter into the jugulars, normally there is no significant bleeding or air embolism. But the pressure has to be a 4-finger pressure, and it has to be a constant pressure for about 15 to 20 minutes. So this is what I thought that I'll share with you. Now, I think we'll proceed with the next program. I don't want to take a lot of time, but I must say that I'm enjoying this, and thank you all.
Thank you, sir. Thank you, sir. Sampath?
Yeah, that was a great journey down the memory lane, and I don't think I need any talk on these topics. I think Dr. Girish should go.